So I'm going to move away from the brain stimulation area, but we are still going to talk a little bit about neuroscience because I'm going to be sort of presenting a broad brush picture of what are some other areas that people have been exploring in research about how we might advance our current treatments for PTSD specifically, and how do we use neuroscience to actually inform that. So I'll be covering a little bit of that, but also then talking a bit more broadly towards the end about some of the other types of alternative interventions that research is currently exploring with PTSD, some of which I'm sure some of you will be familiar with as well. So I think we've already outlined, one of the main issues we've got here with PTSD is whilst exposure-based therapy is our gold standard treatment, it's recommended in all our expert guidelines. This includes imaginal or in vivo exposure. Cognitive processing therapy is also an evidence-based treatment. We've got good evidence that it's effective for about half of the people. But as a clinical psychologist, what keeps me awake is the other half of the people who are either having a partial response or a non-response to our exposure-based interventions. So we've got much research has been done in the pharmacological space over many, many years, a huge amount of funding, and there really are no good first-line pharmacotherapies for PTSD, despite an enormous amount of research. So really, whilst we've got these gold standard psychological therapies that are exposure-based, we still have an issue where we have a significant rate or proportion of people having this non-response. In addition, we do have fairly high dropout rates for our exposure-based therapies, which is another issue that we need to confront. Another really important issue when we're thinking about exposure-based therapy for PTSD is how do we keep people engaged, especially when they're not getting rapid symptom reduction. Just like with some brain stimulation protocols, you're often not getting symptom reduction in the initial few weeks of doing exposure therapy. So what some of the research is looking at when they're trying to look at adjunctive treatments for exposure-based therapy, which is what I'll be talking about predominantly today, is how can we actually speed up the response, if you like, facilitate the response to exposure therapy so that we can actually overcome this issue of engaging people and getting people to actually get a symptom reduction earlier and more efficiently with exposure therapy. This is just an example of the kind of dropout rates that we see in our exposure-based PTSD treatment. So approximately 20% of our clients actually do drop out of exposure-based therapy. There's also a proportion who don't want to do exposure-based therapy at all and won't do it, which is also highlighting the real need for us to have alternative therapies that are evidence-based and have got a good evidence base behind them. What's interesting here is EMDR has also got a fairly high dropout rate. So there's actually no significant difference in dropout rates between these active treatments that we see. They're all hovering around the 20% mark. So again, it's just highlighting we need to find ways to facilitate both treatment response and also ideally encourage more rapid reduction in symptomatology so that we can try and minimise these dropout rates. So the brain stimulation is what Paul's already covered today. I'm going to be focusing more on some of the pharmacological studies that have been done. So there's been a whole range of studies over the last decade or so that have been really looking at what are some of the pharmacological adjuncts that we can use in combination with our exposure-based therapies to try and facilitate and improve our treatment response. And these are just some of them that I'll be touching on and covering briefly. Also, we'll be looking at virtual reality. An area of interest of mine is looking at exercise. There's currently about 3 trials looking at whether adding exercise to exposure therapy may actually facilitate treatment response. And then just discussing some of the evidence for some of these other emerging therapies, particularly mindfulness and the use of assistance dogs too. So most adjunctive treatments that we've got, especially in this pharmacological space, are based on the neurobiology of PTSD. We know in PTSD that there are particular dysregulations, again, with functional connectivity across these broader networks. So in PTSD, we particularly see dysregulations in the salience network, and that really is our threat detection network in the brain. It's our capacity to recognise threat and discriminate it from safe contexts or safe stimuli, and it really does involve this prefrontal and amygdala type of circuitry, or more limbic circuitry. There's also dysregulation in default mode network and the central attention networks as well. But most of the research that's focused around looking at adjunctive treatments informed by neuroscience are really looking within this prefrontal and amygdala sort of connectivity and looking at that salience network. A second aim of a lot of the adjunctive therapies when we're thinking in a pharmacological space is they're really trying to utilise agents that have been shown from animal research to facilitate fear extinction learning. So fear extinction learning is really proposed as a fundamental mechanism that's underlying our exposure-based therapies for PTSD. So the unique thing about fear extinction learning is it's actually a cross-species sort of phenomenon. So we can actually look at fear conditioning and extinction within rodents, look at the molecular functions in the brain that are underlying fear extinction learning. And this got people excited because if fear extinction learning is also a proposed mechanism under our exposure-based therapies, perhaps neuroscience can then inform the development of some of these pharmacological adjuncts. So I'm just going to briefly cover what some of the neurobiology of PTSD is, just to set the scene for understanding how some of these pharmacological adjuncts arrived. So we've got this is actually a meta-analysis from 2012. So it's already in that one, it was covering 79 fMRI studies. There would be well over 100 of these studies now in PTSD compared to either trauma-exposed controls or normal controls. And this meta-analysis is looking at the response in the brain of patients with PTSD to threat stimuli, whether that's looking at fearful or angry facial expressions compared to neutral expressions, or whether that's actually listening to a narrative of the script of your own traumatic experience compared to a script of a neutral experience or a negative one that's not traumatic that you've had. And what is consistently coming out from these studies is that there are significant periods or regions of hyperactivity, which are really comprising this salience network. So significant increases in amygdala activation towards threat, also insula, and also the dorsal anterior cingulate, which has been associated with fear expression and generalised anxiety. All of these, especially dorsal anterior cingulate and insula, are fundamental nodes of this salience or threat detection network. So the idea is there's hyperactivation in these regions, as well as greater connectivity in this salience network. Interestingly, in PTSD, there's also very robust evidence. In fact, the most robust evidence really across most of the fMRI studies is finding a reduced activation in ventral medial regions of the prefrontal cortex. So rostral anterior cingulate, subgenial anterior cingulate is also featuring here, as well as some other ventromedial prefrontal areas. And so this is probably, of all the findings, the most consistent. The idea is these ventromedial prefrontal regions are fundamentally involved in inhibiting amygdala and other limbic arousal networks. So this has basically led to the idea of a fear circuitry model of PTSD. This is a simplified sort of version or explanation, but fundamentally, if you've got impaired ventromedial prefrontal activity that normally inhibits the amygdala, That means if you've got reduced activation in these regions, you're going to have greater amygdala hyperactivity. The idea is that this then results in ongoing conditioned fear responses that are hyper-reactive to threat in your environment. We also know there's clear evidence of hippocampal dysfunction in PTSD, which is also really highly relevant. The hippocampus, we know hippocampal volume is significantly reduced in PTSD. Whether that's actually acquired from the trauma or whether that's a premorbid vulnerability factor is still, there's certainly evidence there's some premorbid vulnerability there prior to a trauma, but also there's also evidence that hippocampal activity and volume is impaired following trauma. And the hippocampus is interesting because it's involved in contextual processing. So some of the ideas around this hippocampal dysfunction is it's actually impairing your capacity to discriminate threat from safety in terms of context. So the idea is that the hippocampus and the ventromedial prefrontal cortex actually are fundamentally important for fear extinction learning. And the amygdala is central to developing our conditioned fear responses. So if we have impairment in our fear extinction networks, it's going to lead to ongoing conditioned fear responses. And this is really characteristic of PTSD clinically. So when we're seeing a client who's having really intense fear responses to trauma reminders, this is an example of a conditioned fear response. Okay. So what we also know is that if we look at, we know that if we're thinking about fear conditioning and fear extinction, we know from fMRI studies where they're doing fear conditioning and extinction studies in the scanner, that there's clear evidence that these networks are dysregulated in PTSD. So this is a recent meta-analysis done of fMRI studies in PTSD patients compared to trauma-exposed controls, where they're doing a fear conditioning and extinction task in the scanner. And what you can see, even though it's only 7 studies pooled, this is 156 people with PTSD and 148 controls, what you can actually see here is during the fear conditioning phase, which is on the left, there's increased activity in the amygdala, insular and dorsal anterior cingulate during that fear conditioning phase in patients with PTSD, suggesting a hyperreactivity of these regions. During the extinction learning phase, so this is when they're learning, they're being shown a stimulus that's no longer paired with a shock or a threat, so they're going to hopefully regulate and reduce their fear. In that extinction learning phase, actually you see increased activity in amygdala and insular and dorsal anterior cingulate in PTSD again, so those things are not being regulated as you'd expect. But you're also seeing reduced activity in ventromedial prefrontal cortex, hippocampus and orbitofrontal cortex. So it's really highlighting these dysregulations we're seeing in PTSD are directly linked to dysregulations we're seeing in fear extinction and also a release or a heightened reactivity of conditioned fear. So that's consistent with the fear circuitry model. Now, if we look at exposure-based therapies, one of the fundamental ideas or mechanisms underlying our exposure-based therapies is that they involve extinction of fear responses. Our exposure to fear trauma memory, so we're exposing people to either memories of the trauma or they're going out and exposing themselves to reminders of the trauma on a day-to-day basis, and they're not having an aversive consequence. Over time, gradually their fear will come down. And we think each time they're doing that, that's an example of fear extinction. So what we did was a very early study was we actually looked at people and we scanned people in response to a threat stimulus in the fMRI scanner prior to and after exposure-based therapy. And this is just in PTSD patients. We didn't have a control group here, but this has been replicated about 3 times in larger trials with control groups. But what was interesting is we saw a correlation between the amount of PTSD symptom change and these fear extinction networks. So basically what we see is as the PTSD's symptoms improve, you actually get a significant increase in these anterior cingulate regions. Equally, you're getting a reduction in amygdala response. So it's really, again, suggesting, yes, underlying exposure therapy are fear extinction networks and their modulation. So we're going to talk about pharmacological adjuncts. So this has set the scene because we've got this beautiful translation between fear conditioning and extinction. We know that these networks are fundamentally dysregulated in PTSD, but they're really key to exposure-based therapies. This has led a lot of neuroscientists to get very excited and to think, okay, if we can actually go back to our animal research and we can uncover some kind of molecular mechanisms that influence fear extinction, perhaps we can trial these as pharmacological adjuncts for during exposure therapy to try and facilitate our response to exposure therapy. So these are just some of the agents that people have trialled, and I'll whiz quickly through this or I'll run out of time. D-cycloserine was really the first of these. So this really stimulated a lot of interest. So it started with animal studies where they actually found that D-cycloserine, which is a partial NMDA receptor agonist, if it was given to rats during fear extinction, it facilitated a fear extinction response. So they were able to reduce their fear more rapidly, shown by a freezing response in rats. Where this got really exciting was Kerry Ressler then actually took this data, and because D-cycloserine is actually we can use it for the dosages that they used in humans were way beyond the clinical dosage. They have minimal side effects. So Kerry Ressler actually looked in height phobics who were doing exposure-based therapy to heights using a horrible virtual floor type of intervention that I'd never do. What he did was did a randomised controlled trial of 5 sessions of this virtual floor therapy where he gave some people placebo, some people, they got DCS. And what he found was that the people who got the DCS combined with doing the exposure on a weekly basis had an improved and more rapid treatment response compared to those who had placebo. So that got everyone incredibly excited about, can we actually facilitate exposure therapy? It's been trialled across many anxiety disorders. So social anxiety disorder was where a lot of the early research started, but they also looked in OCD as well as panic disorder. And there was quite a number of positive early trials suggesting that DCS actually did facilitate response to exposure therapy. However, there's been other more recent trials that have actually found negative findings or null effects of DCS. There's only been 3 or maybe 4 trials of DCS in PTSD populations, and unfortunately there's null effects across the board. The decline study suggested that perhaps if you were a very slow responder to exposure therapy, you may have some improvement with DCS over placebo, but in general, in summary, there's not been a great deal of evidence that DCS is going to facilitate exposure therapy. There was a Cochrane meta-analysis of DCS trials that looked at DCS with exposure across anxiety disorders, and really what they're reporting is quite significantly heterogeneous findings and an overall null effect. And Stefan Hoffman really highlighted in one of his reviews, perhaps this heterogeneity may arise from timing of DCS and dosage, which are always were quite variable across the studies. And he suggested maybe DCS might lead to a more rapid response to exposure rather than a magnitude effect. However, we're still getting null effects there, so it's not really that exciting. Another promising area that people started to look at was cortisol. So we know that people with PTSD have dysregulations in cortisol. We know that cortisol is fundamentally important in the body's major stress system. So PTSD, across meta-analyses, the cortisol literature is messy again because of dosage, circadian effects, and comorbid depression. But a meta-analysis has, which controlled for those factors, which controlled for timing of day, comorbid depression, found that PTSD is associated with enhanced negative feedback inhibition and also chronically lower levels of cortisol, low basal levels. What's interesting is, in both animal research as well as in human control studies looking at fear extinction learning, they found evidence that glucocorticoids in rodents or cortisol in humans, giving patients hydrocortisone to elevate cortisol, actually facilitated fear extinction learning and also fear extinction recall. And this is a recent randomised controlled trial that revealed in spider phobics, they trialled giving people hydrocortisone whilst they were looking at spider images and then approaching a live spider versus just doing placebo. And they found that there was greater reduction in spider fear with the administration of hydrocortisone prior to exposure therapy relative to placebo. So it seemed quite promising. We did a study, this is my PhD student, where we looked at in PTSD samples as well as in healthy controls. We did a fear conditioning and extinction study, and we looked at does cortisol actually impact on our fear extinction learning. And we found that cortisol moderated the relationship between PTSD symptoms and fear extinction. So high cortisol reactivity was associated with lower PTSD symptom severity and improved fear extinction. Conversely, low cortisol reactivity was associated with higher PTSD symptom severity and impaired fear extinction learning. There's been a recent study by Rachel Yehuda. So she published some preliminary data which seemed quite promising. She did a recent clinical trial where she administered hydrocortisone during exposure therapy in PTSD. She did find greater PTSD symptom reduction with hydrocortisone relative to placebo combined with exposure therapy. And she also found greater retention of patients within the hydrocortisone group, and also an association between reduced PTSD symptoms and glucocorticoid receptor sensitivity. So she was trying to look at the mechanism underneath this trial. Disappointingly though, she's now published a larger trial where she found null effects. And there's a recent trial that's just come out looking at virtual reality based prolonged exposure, manipulating cortisol, but this was via dexamethasone, and that led to actually increased PTSD symptoms and dropout. However, dex actually reduces cortisol. So there may still be a story there, but there's conflicting evidence. We've got null effects, we've got positive and negative. So again, not a compelling sign of promise. Others have looked at noradrenaline. So noradrenaline, again, we know is elevated in PTSD, relating to heightened sympathetic arousal that we commonly see. It also is involved in consolidating emotional memories significantly. Might there be a role in fear extinction? In animals, there's evidence. So yohimbine is an agent that can increase noradrenaline release. Propranolol, or a beta blocker, actually can reduce noradrenaline. And it seems to be that noradrenaline facilitates learning. So if you're giving, and it's depending on the timing of yohimbine is important. So if you give yohimbine to increase noradrenaline prior to fear conditioning, it actually increases fear conditioning. If you give it prior to fear extinction, it improves fear extinction learning. Equally, they're finding similar effects with propranolol. So propranolol can actually impair fear conditioning, but it also can impair fear extinction learning. There's been very few human studies, remarkably, looking at noradrenaline and fear extinction learning. One study has examined it and found that propranolol that was administered during fear conditioning, or towards the end of that, actually delayed extinction learning. So there's been a recent trial looking at, okay, if we give, what about if we give yohimbine during exposure therapy compared to a placebo compared to with exposure therapy, and they found no significant effects of yohimbine in facilitating exposure therapy for PTSD. So we're painting a more and more not exciting story, sadly. People have also looked at noradrenaline to try and prevent PTSD. So immediately after having a trauma, you've got about a 6-hour window when your trauma memories are going to be consolidated. The theory is if you have increased cortisol and noradrenaline at that time, it's going to over-consolidate or more strongly consolidate those memories. So there's been several trials. If we give propranolol, and we have to do it, this is the hard part, within that memory consolidation window, often when people are in an emergency, they've often got morphine, they've got other injuries. So trials have tried to give propranolol, and they give propranolol then on a daily basis for a period of weeks in the acute aftermath of trauma. So there's been about 3 randomised controlled trials there. Looking at this, absolutely no significant effects. But the logistics of it, there was variances in dosage, there was variance in time. One study couldn't really get people to take propranolol until about 12 to 48 hours later. So whether you're even near the consolidation window, it may explain those null effects. There's also a lot of interest in propranolol with memory reconsolidation, but again, there's an issue with memory reconsolidation is everyone got very excited about this. Can we bring the memory back? It becomes labile, and then hit it with propranolol and reduce the consolidation. The problem is that we've got significant boundary conditions on reconsolidation. It tends to not work with longer, stronger memories, which is often what we're seeing in PTSD. So maybe there's an application in acute trauma. Oxytocin, they've also trialled because there's been evidence that it also can impact on this amygdala prefrontal sort of connectivity. There's been a few trials using nasal sprays. Again, no significant findings that have really come out from a couple of trials. There's this whole interest in MDMA now as a pharmacological adjunct because, again, there's been some evidence that it can actually facilitate fear extinction in rats, but there's more recent evidence actually showing it impairs fear extinction, so there's not a clear picture there. It has received FDA approval, so there are phase 3 trials moving forward in the US on this. There was an initial RCT which got everyone excited in Lancet Psychiatry, finding evidence that higher doses of MDMA paired with exposure, but only 3 sessions that were monthly apart, actually facilitated PTSD symptom reduction compared to a low symptom group. So they didn't actually have an active control group here, and actually the study itself only had an N of 7 in each of these groups. So we really need significant replication, larger scale studies from independent labs, but also I think the clinical protocol there is one that needs to be considered. So in summary, with pharmacological adjuncts, it's not looking like a compelling story. It's fascinating neuroscience, but sadly, clinically, we're not getting anything that's really that compelling or exciting yet, which I think's sadly a story we've seen with pharmacology for a while. Also, we've got a question of dissemination. Will clients be willing to take these medications? So I also just wanted to briefly mention there's about 3 randomised controlled trials now starting to look at exercise as a adjunctive combined with exposure therapy. Animal and human studies using fear extinction have found that brain-derived neurotrophic factor, or BDNF, actually can facilitate fear extinction learning via activations, again, in prefrontal networks. We did a study where we were measuring BDNF via looking at the BDNF genotype, and we found that people with the low expression BDNF actually had impaired fear extinction learning in PTSD. We also genotyped some of our patients who went through and did prolonged exposure, and what we actually found, again, was the people who had the low expression BDNF allele had a poorer response to exposure therapy than those who had the higher expression BDNF allele. So this led us to the question, if that's actually slowing and impairing if you've got lower levels of BDNF and it's impairing your treatment response, if we can increase BDNF levels, Would we actually be able to facilitate response to exposure therapy? And one of the most robust ways of increasing BDNF levels is actually via acute aerobic exercise. So this has now led there's about 3 different groups now who are getting people to come into the clinic, cycle on a cyclometer for 10 to 15 minutes, trying to get them to a certain VO2 max to raise BDNF levels, and then they're immediately doing exposure-based therapies afterwards. None of these studies have yet got any data coming out, so it's in the experimental phase. But something that excites me about that is the dissemination potential. I think that many clients actually are attracted to doing exercise, and clinicians also feel comfortable with working with exercise. And I think also it may have benefits for physical health, where we know our PTSD patients often have metabolic syndrome, cardiovascular issues, and so forth. So jury's out on that one. Virtual reality, just briefly, we know there's an increasing evidence for the efficacy of VR-enhanced exposure-based protocols, especially for military veterans. So they've created really sophisticated VR environments around Iraq and Afghanistan, and they're showing in several trials now good efficacy with the VR therapies. However, they haven't compared standard PE to VR PE as yet. I think that's underway. Also, some interesting new developments are looking at surround sound VR, or sort of a surround VR environment, these Karen systems, and they're trialling people actually moving and walking towards threats in their environment. The idea is walking towards will actually overcome avoidance. So, and also, they're also trialling that with EMDR as well, all integrated. Again, no evidence is really coming out from RCTs as yet, but those trials are underway. I just wanted to mention mindfulness interventions because it's certainly increasing evidence is suggesting that mindfulness may be an effective intervention for reducing PTSD, but also for general anxiety and depression, often comorbid with PTSD, not ignoring those comorbidities. And mindfulness interventions have been shown to regulate amygdala reactivity, increase networks in the brain that are involved in emotion regulation. There's been a lot of pre-post designs. So, the research evidence for mindfulness was really quite poor for a long, long time. But increasingly, there's now RCTs that are looking at active controls compared to these mindfulness interventions, and they are finding a significant effect of, reducing PTSD symptomatology. Assistance dogs is also another area that people are very interested in, especially with veterans. And there are several trials. Again, there's been some smaller case series studies going on looking at the effectiveness of assistance dogs, but there's ongoing trials happening currently. And just the intensive treatments as well. So Phoenix has been doing a Restore trial looking at how do we deliver prolonged exposure. So often it's very hard to get a client to engage in very intensive exposure therapy over a 10-week period. So there's now been 3 or 4 trials, and Phoenix is currently doing one, looking at comparing doing prolonged exposure on a daily basis for 10 days compared to weekly basis for 10 weeks. And some of the early RCTs coming out there are showing some really promising effects that it may be equally effective. So again, just giving us some flexibility in how we may be able to deliver some of our interventions. So in summary, while we have established treatments for PTSD, we've got limited efficacy. We've still got 40-50% of clients only showing a partial and inadequate response. So it's crucial we find ways to improve our treatment response and find alternative evidence-based interventions. Much interest in the pharmacological adjuncts, but really it's not looking very promising at all in terms of the research that's currently coming out. Brain stimulation therapies are certainly looking promising, and I think will be developing significantly over time. Mindfulness interventions also are appearing promising as an alternative intervention, and there is a potential for exercise protocols and some of these more VR-enhanced protocols into the future. Thanks.